Welcome to Hand Surgery Resources podcast on mucoid cysts of the hand and digits. Mucoid cysts are benign solitary round to oval skin-colored lesions. They are also referred to as mucinous cysts or myxoid cysts. Mucoid cysts commonly occur in women, usually on the dorsum of the DIP joint. The skin covering a cyst can be very thin, sometimes even translucent. Thus, minor trauma can cause the cyst to rupture and deflate with spontaneous drainage of a clear jelly-like material. A typical presentation of a mucoid cyst could be a 65-year-old female with a history of osteoarthritis who is complaining of a lump at the distal aspect of the index finger. The lump appeared spontaneously a few months ago. She has noted the lump has fluctuated in size. A week ago, she accidentally banged her index finger and the lump ruptured and drained a thick clear jelly-like material. The lump deflated, but after 2 or 3 weeks it returned again. She has had only mild pain in the DIP joint area. She has also noted a deforming ridge developing in her fingernail. This is a classic history of a patient with a mucoid cyst. Mucoid cysts are benign digital ganglions usually on the dorsum of the DIP joint at the base of the fingernail. They originate from a mucoid degenerative process occurring in the DIP joint capsule. Osteoarthritis with osteophytes at the DIP joint are commonly associated with mucoid cysts. The thin-walled mucoid cyst contains a jelly-like clear mucinous material which appears to be concentrated synovial joint fluid. A mucoid cyst appears as a soft tissue mass, but as seen in this patient, it is frequently associated with bony hard osteophytes called Heberden's nodules. As would be expected, the examination of a finger with mucoid cyst shows a circumscribed, frequently translucent mass at the base of the nail over the dorsum of the DIP joint and the terminal extensor tendon. Nail deformity, i.e., ridging, is often seen with varying degrees of tenderness in the joint and associated with the cyst itself. Because of the associated osteoarthritis, decreased DIP joint range of motion is common. The finger with a mucoid cyst should be X-rayed to evaluate the associated arthritis. The X-ray typically shows a soft tissue shadow caused by the cyst. Classic kissing dorsal osteophytes at the DIP joint are not unusual. The osteoarthritis will also cause sclerosis in the DIP joint. The cystic nature of the mucoid cyst is easily confirmed by ultrasound, which can also verify the presence of osteophytes. A mucoid cyst may have a scarred skin surface secondary to repeated ruptures and recurrences. Occasionally, the simultaneous occurrence of 2 mucoid cysts can occur in digits of the same hand. Non-operative treatment options for the mucoid cysts include simple observation. Occasionally, a mucoid cyst can resolve without therapeutic intervention. Other non-surgical treatments include aspiration with or without the simultaneous injection of steroid, cauterization, and freezing with cryosurgical techniques. The patient often requests an aspiration. Patients should be cautioned that aspiration should not be done at home. The cyst frequently communicates with the DIP joint via a sinus-like tract. Therefore, aspiration without sterile technique could lead to a joint infection. A properly done aspiration should be done with strict sterile technique, usually under local anesthetic. For example, after a 1% local anesthetic injection, the cyst can be aspirated with an 18-gauge needle. When inserting the needle, avoid the digital nerves and go through an area where the skin is relatively intact. It is usually possible to feel the needle pass through the wall of the cyst and visualize mucoid material going into the syringe. After removing the needle, the cyst will be manually compressed to push any remaining mucinous material out through the needle track and further deflate the cyst. Surgical options for treating mucoid cysts include excision of the cyst with or without excision of associated osteophytes from the arthritic DIP joint. Most surgeons, however, do recommend the simultaneous removal of osteophytes associated with a cyst. It is rare that skin flaps or skin grafts are needed during the surgical removal of mucoid cysts. However, occasionally a large cyst with thin translucent skin cannot be successfully resected without creating a skin defect which requires a small skin graft. The defect can be covered with a split-thickness skin graft. Ideally, the patient should be made aware of this possible need for skin grafting and where the graft will be taken from during the patient education before surgery. The patient should also be aware of this skin graft sometimes result in graft color that does not exactly match the color of the skin of the finger. Therefore, the graft can be relatively obvious and sometimes a cosmetic concern. When planning an incision for removal of a mucoid cyst, the various anatomic components of the fingertip that might be affected by surgical excision should be kept in mind. For example, the terminal extensor tendon is often immediately adjacent to the cyst. This tendon inserts just before the base of the nail into the dorsum of the distal phalanx, and injury of this small tendon and its insertion site must be avoided. In addition to the extensor tendon, the surgeon should also avoid injury to the digital nerve. The ulnar and radial digital nerves are just dorsal to the DIP joint crease on the side of the finger. In the middle of the middle phalanx, the nerve divides into 3 branches, so there is one dorsal oblique nerve branch that is located in the area adjacent to the typical mucoid cysts location. In addition to the nerve, there are also dorsal veins present. Typically, at this location, the 2 lateral dorsal veins coalesce to form a single central vein. Sometimes this vein can be preserved, but this vein can be cauterized if necessary. If possible, incisions for removing mucoid cysts should avoid the eponychial fold. This fold is dorsal to the part of the nail plate that covers the nail's germinal matrix. The white portion of the nail, or lingula, includes the germinal matrix. Distal to the lingula, the nail adheres to the sterile matrix. The nail is surrounded on the sides by lateral skin folds and at the tip of the finger by the eponychium. Finally, before making the incision, note the presence or absence of Heberden's nodules and the DIP joint range of motion. In many cases, there is a reasonable amount of normal skin between the mucoid cyst and the eponychial fold that can be left intact. Therefore, a simple longitudinal or slight oblique incision is appropriate. This incision can be placed directly over the cyst while protecting and not entering the eponychial fold skin. The cyst can also be removed with a transverse incision, which can also easily be turned into an L-shaped incision to make a flap to expose the area of the cyst. Another option is an H incision, where the incision creates a proximally and distally based flaps. These incisions all allow excellent exposure of the extensor tendon and the cyst. Some surgeons use a U-shaped incision with a central proximal extension to expose the mucoid cyst. Another alternative is an S-shaped or zigzag incision, which allows 2 flaps and good exposure for the cyst. The incision is along the edge of the extensor tendon and allows the tendon to be visualized and protected. The skin edges are retracted delicately with skin hooks. After the extensor tendon edge has been exposed, the cyst is dissected free from the tendon. The cyst and any extension into the DIP joint capsule by the cyst stalk are excised. The mucoid cyst excision requires delicate dissection with a fine scissors such as an iris scissors or an 11-blade scalpel. When performing the excision of the mucoid cyst, the eponychial skin fold tissue must be handled carefully and preserved. The preserved fold will maintain the normal appearance at the base of the nail. After removing the cyst and its stalk, any osteophytes are removed with a small rongeur. Surgical complications are extremely rare. Possible complications that can occur are infection, cyst recurrence, new or persisting nail deformities, DIP joint stiffness with or without persistent swelling, and of course post-operative pain and discomfort. Educating the patient regarding the cause of pain before operation is very important. The pain and tenderness can be secondary to the swollen, frequently inflamed cyst, but it can also be from the osteoarthritis of the DIP joint associated with the cyst. The cyst and the osteophyte can be removed, but there is still potential pain from the painful osteoarthritis secondary to the remaining arthritic joint. To completely control any post-operative pain associated with the DIP arthritis, a surgical fusion of the DIP joint would be necessary. There are also risks of not removing a mucoid cyst. These include nail deformities such as ridging and dorsal DIP skin infection or DIP joint infection if a ruptured cyst allows bacteria to invade the skin or DIP joint via a track through the cyst into the joint. To summarize, the key points that are related to mucoid cysts and their treatment include: 1. Mucoid cysts are small ganglions at the dorsum of the DIP joint at the base of the finger. 2. Mucoid cysts are usually associated with DIP joint osteoarthritis. 3. Mucoid cysts communicate with the DIP joint and are filled with a mucinous material which is derived from the synovial fluid of the joint. 4. Pain associated with mucoid cysts can be from an inflamed cyst, from the DIP joint osteoarthritis, or from an infected ruptured cyst. 5. Excision of the cyst, stalk, and osteophyte yields consistently excellent surgical outcomes. 6. The terminal extensor tendon, eponychial fold, and nail germinal matrix must be protected during surgical excision of mucoid cyst. 7. There is a 50% recurrence rate that should be expected when one treats a mucoid cyst by aspiration alone. Thank you for listening to our podcast on mucoid cysts. If you would like more information on hand surgery topics, please see Hand Surgery Source on our website at www.handsurgeryresource.org or download the Hand Surgery Source app from the Apple Store or Google Play.